Okay, so we'll continue. And I think the last case we looked at was this case, and there was a history of calcification on the X-ray. So this is a Bennett lesion that we talked about. It's hard to see the calcification on MR, but we can see that there is a tear of the posterior labrum, which is displaced, and we got marked thickening of its periosteal attachment, and we talked about that last time. So Bennett lesion. So why don't we start here, and Jonah, what do you think of this case?
Alrighty, so here we have a 27-year-old male who is a baseball player and is complaining of shoulder pain for 3 years. So let's see, we've got multiple axial images, and, a couple coronals of this patient's shoulder. Looks like. So let's see. Well, we're seeing some irregularity of the posterior aspect of the labrum there. We're seeing some kind of linear fluid coming down. And okay, now we're looking at a couple of radiographs of this patient. And, so it looks like we've got, yeah, so we're just seeing irregularity kind of the posterior glenoid and a little calcification by it. Okay, now we've got CT as well, and yeah, this is really confirming the suspicion pretty well. So it looks like we've got a little fracture posteriorly. So
yeah, now this is probably not a fracture.
Or yeah, sorry, rather probably an avulsion.
It just shows you that this is kind of confusing on the MR. On the MR, what we can see is that there is this dark line that parallels the posterior cortex. And looks like it's associated with the posterior labrum, but we don't really see a discrete labral tear in this case. We just see this little dark black band here. If we go to the plain films, you can kind of see a little bit of the calcifications here associated with the posterior glenoid. And then if we go to the CT scan, here we can see it. And if you notice that this looks like that periosteal attachment of the labrum that we saw before in that Bennett lesion. And this is calcification right along there. Here's what the MR and the CT scan look like.
Okay.
Really, this calcification is really outside the bone. And this is a Bennett lesion. Okay. So often you'll see a nice discrete tear of the posterior labrum. Sometimes this is just trauma to the posterior labrum that's common, that's chronic. And then when you have healing, you get calcification in that area. So this is the Bennett lesion. And a lot of these people have some degree of posterior instability and symptoms associated with it. And here we can also see that there's some eburnation of the cortex posteriorly in the subchondral bone, all due to repetitive trauma there. And it can be either due to a traction injury from the inferior glenohumeral ligament or a traction injury from injury to the labrum. In this case, it's probably primarily the inferior glenohumeral ligament. And it's usually associated with other degenerative changes and wear and tear within the shoulder. Okay, Max, what do you think of this? John, go ahead.
Yeah, Bennett, I think his history tells us, in Campbell's anyway, described the calcification, didn't describe a avulsion of the labrum.
Yeah, he just described the calcification, right?
Yeah.
Yeah. And what we generally find now is that calcification is kind of associated with injury to the labrum and injury to the posterior band of the inferior glenohumeral ligament attachment. So it's probably a traction injury.
So I don't think we should probably use a Bennett lesion as such.
You shouldn't. That shouldn't be a diagnosis?
Probably not. Yes.
What would you recommend if we see this?
And just what you see.
Oh, just what you see. Describe it. Yeah. Well, I don't disagree with that.
Because I think most younger guys will not know what you're talking about. The old timers will remember it, but the youngsters won't.
Okay.
Like our fellows, you know.
Okay. Right.
Just kidding.
I have two fellows here. Have you heard of Bennett lesions? Okay. Okay. All right. Max, what do you think of this case?
Okay, so 18-year-old male with instability. I think the left.
I can't hear you, Max. Yeah. Can you talk a little louder?
Let me see. Can you hear me now or no?
That's better.
Okay, so we have two axial series. I believe the left one is a proton density fat set, and
This is a
the right.
T1, and this is a PD fat set. The left is T1, the right is PD fat set.
Okay, so 18-year-old with instability. We have there's some focal thickening of the posterior glenoid, and there is.
Wait. What are you talking about? This or what?
Yes, just right there, that
right
area, right? Yeah, no, more, even more posterior. That
but this is the posterior edge of the glenoid here.
Right, but the cortex is that dark line, and then after the cortex and the posterior, right?
Okay, but this isn't glenoid here.
Okay, so this would be some extraarticular process that's growing around the glenoid, some soft tissue.
Well, what's this?
That must be the posterior labrum.
Okay, so what would this be?
Looks like the posterior labrum is fractured, and I'm sorry, is torn, and there is intermediate signal intensity along the periosteum of the posterior glenoid.
Okay, so this is the labrum. This is the periosteal attachment that's very thickened here, like we've seen in the last couple of cases. Okay, and then this is actually a tear, and you have a displacement of the labrum off of the glenoid. Good. Okay. And there's also probably a little injury to the subchondral bone here as well. And it's hard to see, but there's probably some thinning of the articular cartilage there as well. So what are we dealing with?
This must be a athlete with trauma, and this is basically a Bennett lesion or posterior labral.
Okay. Okay, and then here's a sagittal image, and what we can see here is flattening of the posterior aspect of the glenoid, and then this is that displaced labrum. So this patient probably has had a posterior injury with actually an injury to the subchondral bone, and this is what the CT scan looks like. So what are you seeing on the CT?
So this is on the CT, we see a small bone fragment arising from the posterior glenoid, likely a periosteal avulsion, sleeve avulsion, and there's also some retroversion of the glenoid itself. It may have contributed to this.
So this calcification here is probably this, which is probably more calcification of the periosteal attachment and the labrum. What we see is marked flattening of the posterior glenoid, which should be rounded. And this patient has probably had a posterior dislocation event, and as you said, a fracture of the glenoid rim. And if you also notice here, the patient has a retroverted glenoid. If we go through the angles we talked about before, this would be very abnormal. It really should come out more like this. So if we did all the angular measurements, this would be a very retroverted glenoid. So this patient is at high risk for posterior instability, and we're seeing all the changes from the posterior instability. And it just shows how much easier you can see the calcification on the CT. When it's prominent like that, we can infer it on the MR, but it's really hard to actually see the calcification on the MR. We can infer it, but you can see it very nicely on the CT. And
so, Shona?
Yes.
What clinical condition do you think this patient have?
Clinically, well, probably some instability and some pain.
Well, that's a given. I was thinking about epilepsy. Grand mal seizures, probably from birth.
Oh, yes.
I'm not sure. I don't know whether that's a history, John, is it? I don't know.
I don't know this history. This patient has very well developed musculature here. I'm not sure whether the patient has that or whether they just have a congenital retroverted glenoid, and the patients had repeated posterior instability events being an athlete. I don't remember that part of the history. Yes?
Like, just based on the CT and even the MR, can you tell for sure that there wasn't a prior, like, posterior dislocation with an old fracture? I mean, how can you tell the difference?
I think that this is a posterior dislocation with a fracture of the glenoid rim. But this calcification is probably not from that. If we go back and look at the MR examination, this corresponds to the black line that we saw for the displaced labrum and the periosteal attachment. Yeah. So again, this is under the kind of the rubric of a Bennett lesion, which is really an injury to the soft tissues which attach back here, either the labrum and the periosteal attachment or the posterior band of the inferior glenohumeral ligament. And then when the body tries to heal that, you get calcification in that area of injury. Both are highly associated with posterior instability. And that's really, and the Bennett lesion was important back in the days when we just had plain films to evaluate, because it's something you could see on a plain film that would infer the fact that you have injury to the posterior glenoid. Now with MR and CT, as John was saying, the concept of the Bennett lesion really isn't important anymore, because we can actually see the anatomical injuries which are both associated with and lead to further posterior instability. Okay, let me just see. So Jeff isn't with us yet. Okay.
So you have a 20-year-old female, rule out labral tear, of coronal T1 and coronal PD fat sat images. A patient who's had an arthrogram. So looking at the labrum for what we can see on here, I don't see any discrete abnormalities. There's a subchondral cystic change or a traction cystic change on the greater tuberosity, some signal, maybe some tendinosis within the infraspinatus muscle.
So this is 53008. Now notice the subchondral bone here and how typically the margins of the glenoid all the way around should be quite prominent, because the margins of the glenoid are really the bony buttress which adds stability to the shoulder. So when you see the margin blunted like this, we saw it when we talked about retroversion of the glenoid, which is highly associated with posterior instability. And with that congenital anomaly, you would often see some, instead of the nice sharp buttress of the edge of the glenoid, it would become rounded like this. And here we're seeing it inferiorly. So I would be concerned about that. Especially in someone that they're concerned about a labral tear, because they're probably concerned about instability. Here we go, the axial images. What do you think here?
So axial T1 and PD fat sat, and so more posteriorly, there's some high signal intensity within the region of the posterior labrum, which may represent some contrast imbibing underneath the labrum. There's also a lot of thickening and low signal intensity posterior to the cortex of the glenoid and itself. And again, like you mentioned, that irregular, almost rounded morphology of the posterior inferior glenoid.
So there are a number of changes here that should make you very concerned about posterior inferior instability. And this is really thickening of kind of that cortex there. And in this particular case, this is really abnormal underneath the labrum. And we can see some irregularity there. This turned out at surgery, this posterior inferior labrum was very soft. It very much, if you pressed on it, it would just give way. And this patient had a history of instability here. And this is called a Chem lesion. And it's really an injury to the undersurface of the deep part of typically the posterior inferior labrum, where it's a lot like, if for those of you who are pool players, you have the bumper around the edge, and if you have a nice bumper, the balls bounce off of it nicely. But if you actually took out the inside of the bumper, then the ball would hit it and not bounce off. So this is really an injury to the inside of the labrum, which keeps it from being as rigid as it normally would be, which then it no longer acts as a good bumper, and it leads to instability of the shoulder. And I don't know of any great papers in the literature which have correlated MR findings with what have been Kim lesions at the time of surgery, but here we can see that there's some signal change within the labrum. We can see that the underlying subchondral bone is rounded off, so you would guess that it would be unstable. And then here we can see marked thickening of the periosteal attachment, which goes along with a chronic repetitive trauma and instability. So these are the kinds of things that you can see in a Kim lesion. This was on 5/30/08. And here's just it's considered an incomplete avulsion, but in this case it's just an injury to the deep surfaces in arthroscopy. Now this is that same patient. Let's see, this is in 2008. Here's the patient 3 years later.
Okay, so axial PD fat sat and T1 weighted images. So now there's more irregularity of the posterior aspect of the glenoid, and it's more jagged in appearance. And the labrum itself is even more irregular in terms of its signal and morphology. Okay, and then the coronal T1, it's more thickening and that bowed appearance of the posterior inferior glenoid.
Yeah, and this patient continued. Okay, and then what do you do? If the patient has significant instability, then some people will go in and do a labral repair, where they will free up the labrum. They'll put it in a position where it can buttress the joint space, and then put it down with suture anchors to try to stabilize it. Treat it as though it's a tear, even though when you go in there, you actually don't see the tear because the surface is still intact.
"24-year-old male, shoulder pain, clinical impression is labral tear." So we have multiple axial PD fat set and looks like just PD. And there is an arrow, arrow sign. So it looks like the posterior glenoid, there's some subchondral edema, or like, and just, yeah, so irregularity. And the cartilage, I think it's kind of hard to see, but it's okay. But it kind of like, it involves the posterior periosteum of the glenoid, and on the coronal images, again, it just shows that there is a area of increased signal in that subchondral glenoid in the first image to the left, and then some perilabral cyst. It looks like there is like posteriorly small, so it just indicates that there is some labral pathology that we may or may not see. There's a tear there. So it's like a posterior inferior labral tear with a perilabral cyst. Rule out Kim's lesion. So, quick question: Kim's lesion, is it arthroscopically evident or not evident?
The classic Kim lesion was described as the surface of the labrum was intact, but when you make the diagnosis by probing on it, and it does not resist the probe. Okay. And therefore, when you have forces on the shoulder to bring the humeral head posterior and inferiorly, there's nothing to buttress it, and you have instability because of that. And so it's really considered to be an injury to the deep fibers of the posterior inferior labrum, so it doesn't function properly.
Kim described an operation, posterior dislocation.
Yeah.
And in terms of Kim lesion and Campbell's, it's really not talked about. It's just a posterior dislocation with avulsion of tissues like labrum and so on.
Yeah.
Same thing. Bennett described a triceps avulsion as being a cause of the Bennett lesion. So it's only when arthroscopy came into existence did the Bennett lesion become a so-called Bennett lesion, the term is used now, but it's being discarded in orthopedic literature.
Okay.
Basically, an orthopedic, I mean, it's a posterior dislocation with calcification.
Great. Yeah, I had forgotten that it was. He originally described it as a triceps avulsion.
Correct. So that, like I said, orthopedic residents and so on, I'm not sure they're going to be calling this because
Bennett. Yeah.
everything, eventually the names kind of go away.
Okay. Thank you.
Except for mine, of course.
Yeah, we'll keep the Agudas.
Right.
Yeah. Okay, and then these are just further posterior inferior labral injuries that we've been talking about. Okay. Okay, Jonah, what do you think of this one?
Certainly. So we've got axial images, including an arthrogram of a 33-year-old male, also sagittals along the bottom there. So what I'm seeing is some flattening and actually a kind of linear signal through the posterior labrum. Yeah, especially on that arthrogram image, actually, that's showing it well dissecting through. Probably a little bit of paralabral cyst or something there, too. So, okay, we at least, have a posterior labral tear.
Okay, yeah, that's what it was. So just showing you a lot of different findings of these posterior inferior labral, and I think it's good to see the spectrum of different findings rather than just one. Max, what do you think of this case?
So 24-year-old, the Major League Baseball pitcher, new clicking, history of labral repair. So it looks like we have a labral repair with surgical anchoring in the glenoid. Posterior glenoid is hypertrophied and actually that may be a graft that they put in here. That's the graft. And then there's a signal intensity between the glenoid and that graft right there.
Well,
and
this is not a graft. This is not a graft.
Okay, so this is a hypertrophy posterior labrum. So this, and there's a small signal deep within it.
Okay. Here's the ABRA view.
So this looks the posterior labrum looks very irregular, and this little signal intensity is also irregular in shape, nodular and slightly curvilinear. So this is is it an arthrogram, I presume? Or?
Yeah, this is an arthrogram.
It's contrasted in the context, so it's got to be.
What is the axial view?
Again, there's some thinking, but right, it doesn't look like there's any tear of the labrum on the arthrogram, though.
Well, wait. Now we're high. We're way up high here. The labral injuries for instability tend to be lower, and then what we have here is an old Hill-Sachs impact, right? And then what this is actually the glenoid here. So it's a retroverted glenoid, and this is one of the congenital anomalies we talked about, where the glenoid was insufficient. And in development, what happens then is that the body created a very large posterior labrum. But as we talked about, this is a very unstable congenital anomaly, where when you stress it, the weak link is between the hypertrophied labrum and the posterior part of the glenoid here. This tore. They went in and did a repair, but he continued to pitch at the major league level, and the repair didn't last very long. And so this is a congenital anomaly with a retear after surgery. And here's just another more extreme example of the same sort of thing, a retroverted glenoid. Obviously, this is going to be unstable. The posterior glenoid should be out like this, not down like this. We have a tear of the articular cartilage. This is an enlarged posterior labrum congenitally, and we have a displaced tear. And this is obviously going to be a very a congenital configuration which is going to intrinsically be unstable. And if you do athletics, you're going to put a lot of stress on this posterior labrum. And tears are very common with this kind of dysplasia of the glenoid. Okay.
I'm sorry, quick question on the previous. That case, you said it was a Hill-Sachs deformity, but that's from anterior dislocation. But this one has like a posterior instability, right?
This patient had both. Oh. This patient early had a multidirectional instability, but had both anterior and posterior dislocations. Pretty rare example. Okay. Let's see. Max, is it your turn?
He just took it.
Oh, you just took it? Sorry.
26-year-old with abnormal x-rays and multidirectional instability. So we have axial PD fat set and axial T1 arthrogram. And so there's a large Hill-Sachs lesion on the posterior aspect of the humeral head. There's a dysplastic appearance to the glenoid. Doesn't look as deep as it should, and there's a large fracture with avulsion and retraction of the proximal or the posterior aspect of the glenoid.
Do you call this a fracture?
It looks like there's a piece of bone that's been pulled off, like on the T1 image. Yeah, looks like a piece of bone. Well, there's something that's somewhat corticated along the posterior. It looks like a fracture. And there's a large amount of contrast in the joint space.
And this is actually an abnormal location for Hill-Sachs. This is much lower than the typical Hill-Sachs is. And what this was another case of dysplasia with a small retroverted glenoid and a tear of the labrum, of an enlarged labrum. And this is multidirectional instability, very similar to that last case.
So that one has Hill-Sachs and reverse Hill-Sachs, this one?
I think this is a normal contour here.
Oh, okay.
Okay, well, let's go on to inferior labral tears. So I think we've exhausted posterior labral tears. So you can get it from anterior dislocation. There's the HAGL lesion, the reverse HAGL, the GAGL, and the GLAD. So we'll talk about these kind of lesions. Here, what do you think of this one?
We got a 29-year-old male with skiing injury 1 week ago, ruled out rotator cuff tear. We have 3 coronal images, PD fat sat. The rotator cuff tendons, from I think it's like a supra, it's actually intact, maybe a little bit of mild tendinosis, no rotator cuff tear. There is edema of the humeral head and near the insertion, probably some traction changes, but then the abnormality is the green arrow. It looks like that the inferior glenohumeral ligament is avulsed from its humeral attachment. So with the I'm not sure if that was contrast given or not, or maybe it's too bright. Yeah. So there's a contrast extravasation from the axillary pouch. So this is a HAGL lesion.
So this is a superior kind of Hill-Sachs. This patient had an inferior dislocation, and the greater tuberosity impacted along the inferior glenoid. And in order for that to happen, the inferior glenohumeral ligament has to be torn. In this case, as you said, it was avulsed off its humeral attachment, which would make it the HAGL lesion. Great. And you may or may not get an inferior labral tear with these. In this particular case, the inferior labrum looks like it's intact. Though again, I'm a little concerned that there could be a little dysplasia of the glenoid that might have predisposed the patient to have an inferior dislocation, which would make then the treatment more difficult. Okay. So I think, let's see, Jonah, is this normal or abnormal?
Probably normal variant here, I think. Yikes. So, yeah, we've got a nasty inferior dislocation, Hill-Sachs type deformity.
So this kind of shows the mechanism here. In this particular case, there's more injuries than we saw in the last one. But you can see the inferior displacement, the impaction injury involving both the labrum and the inferior glenoid, as well as the superior aspect of the humeral head. And here you can see the supraspinatus tendon being pulled over here, as well as the long head of the biceps coming down. So that this is from from France, where I guess they were able to scan this patient in the scanner and scan him. Whoa.
Probably a neck injury too.
Yeah. Yeah. Let's see. Yeah, we don't see it well here, but that's right.
No, the muscles look.
Yeah. And then here we can see the empty glenoid fossa sign, and then all the tendons being stretched. So that's an inferior dislocation, and we normally see, yeah, this looks like. All right. Let's see, Max, what do you think of this, John?
A lot of nerve, probably.
A lot of what?
Nerve root injuries of the cervical spine.
Yeah, I would be concerned about that. Yes, traction injuries. Max, what do you think of this?
Right, we have coronal and axial images of the shoulder demonstrating Hill-Sachs deformity. Looks chronic. There's no edema there.
Yeah, I wouldn't call this Hill-Sachs. Or if you did, you'd have to say it's a superior Hill-Sachs. The normal Hill-Sachs is posterior to this. See, this is right under the supraspinatus tendon, and the mechanism of injury of this is different from a typical anterior dislocation.
Okay. And then you have thickening of the inferior glenohumeral ligament, and as well as the inferior labrum is irregular, and there's definitely abnormality within the glenoids as well at the inferior labrum.
Yeah. So this is the patient. Yeah, this patient, and we have an anterior labral tear as well. This is a patient who had a straight inferior dislocation rather than the typical anterior dislocation. This is an impaction fracture, so it's like a Hill-Sachs, but this one dislocated inferiorly rather than anteriorly, which is much less common. And I think it's important to describe that because this is really a different mechanism than the typical shoulder dislocation. And so I think it's important to describe that to make it clear that this is really an inferior dislocation rather than an anterior dislocation.
Okay. So you have a 30-year-old male after a motorcycle accident. We have two views of the left shoulder that demonstrate inferior and anterior dislocation of the humerus, and then now they've been relocated. So we have a coronal T1 and a sagittal T2. So on the coronal T1 image, there's some irregularity where the supraspinatus tendon inserts on the humeral head, but there's also, looks like a cortical defect. I don't see, there's a little bit of low signal intensity within the marrow. And then so there's probably an acute fracture of the superior aspect of the humeral head there because of the inferior dislocation. And then you're encircling this low signal intensity within the axillary pouch. So as of now, I'm not sure whether that's a bone fragment or something else.
What is this?
And so the low signal intensity band that's undulating could be a superior insertion of the inferior glenohumeral ligament anterior band. And that looks undulating, so it's probably torn at its inferior attachment. Was that the low signal intensity on the coronal image?
And this is actually a part of the displaced tear of the anterior band of the inferior.
Okay.
And then here we can see an
inferior tear.
And if we do the ABRA view, we can actually see the labral tear here going anteriorly. So this is primarily an inferior labral tear, but also extending a little bit anteriorly. Now, in a minute, I'm going to talk about this distance and what this can signify. But I don't think we're going to talk about that now.
Okay, we got two coronal, looks like a PD fat sat arthrogram of the shoulder. We have this kind of like multilobulated signal in the inferior labrum is like a paralabral cyst, which is not as intense as the arthrogram. So, and then there's like a little bit of a cleft. Looks like the inferior labrum. There's like a little non-displaced tear. partial thickness tear of the.
So that's an inferior labral tear with a little paralabral cyst. And then in the ABR view, you can see that inferior tear extending into the anterior inferior labrum there as well.
Do you like to say when you see a labral tear, like superficial or at the base of the? Do you try to classify if it's superficial or at the base of the labrum? Do you like?
You mean whether it goes
like
down and is just
on a triangle? Is it closer to the bone or is it actually away from the bone? Like if it's at the tip of the labrum?
Yeah, I certainly like to describe whether I think it's at the labral bone junction. Or just within the labrum itself. Okay. And usually if it's a labral bone junction, it's unstable and displaces.
Right, okay.
Yeah. Okay, and here's just another example of an inferior labral tear. It's a little hard to see the tear itself, but you can infer it because of this paralabral cyst is classically seen only in the presence of a labral tear, where joint fluid goes through the tear site, which is here, into the paralabral cyst. And these inferior cysts, fortunately, most of the time they're not very large, but when you see these, I guess I should have asked someone else. Jonah, if you see a paralabral cyst inferiorly here, what else do you have to evaluate?
Yes, well, I think what we're basically getting at here is quadrilateral space syndrome.
Right.
And in that case, we'd want to look at teres minor and deltoid, see for there's fatty infiltration.
So you then need to look at the sagittal images and see if there is edema or atrophy involving the infraspinatus, and sometimes it can extend up into the supraspinatus. Yeah. Okay. Max, what do you think of this case?
All right, so we got a coronal image of the left shoulder. I think this is a PD fat set with orthogram. So we got a small low signal intensity structure, kind of wavy appearance coming from the inferior labrum. So I wonder if that's a torn.
So here's the axial image. What do you see on the axial image or the arthrogram?
So we see a small sliver of signal intensity extending along deep to the anterior labrum right there. So it looks like there's a tear.
So this is a tear of the labrum, and what we see here is actually this is a flap tear, and the flap is displaced into the inferior recess, but it's still connected inferiorly here. But this is all a flap tear of the labrum, and here it is in the axial plane, that labral flap. Okay.
Normal for the patient, I guess. So we have a coronal T2-weighted image, and there's extensive cortical irregularity of the lateral aspect of the humeral head. The deltoid muscle has some edema within it, and there's a lot of fluid interposed between the deltoid and the humeral head. The supraspinatus insertion is regular with some full thickness tearing and retraction. And then in terms of the inferior aspect of the capsule, it looks like it's some thickened, and I don't know if there's atrophy of the musculature of the deltoid or if that's normal in terms of the muscle bulk. But there's also this, almost looks like this serpiginous low signal intensity that's interposing between the deltoid and the humeral head. You can see it also within the quadrilateral space. I'm not really sure what that is coming from. Yeah, or if that's normal fat. It just looks irregular.
So what's happening here?
Looks like there's thickening of the inferior aspect of the capsule, and I don't see any continuity on this slice right now to touch on the humerus.
So here the interglenohumeral ligament is torn.
Okay, so then maybe from an inferior dislocation.
So this, and so here we can see this is probably an inferior dislocation, a superior Hill-Sachs impaction injury, associated with a tear of the rotator cuff to the bone here. There's probably a lot of chronic things going on here. This is probably chronic synovitis and the subdeltoid bursa. I forgot. I'd have to look at other images to see whether this edema, but my guess is we're dealing with an acute strain of the deltoid here. And then we can see a tear of the inferior glenohumeral ligament. And it's a little bit unclear whether this is just a tear very close to the HAGL to the humeral attachment of the inferior glenohumeral ligament, or whether this is kind of a mid-substance tear, or whether it's an avulsion actually off the bone. It doesn't really matter, but it's certainly an injury to that inferior glenohumeral ligament. And again, it really looks like it's thickened here, so this is probably an acute on top of a chronic condition. So this is probably not the first time they've dislocated their shoulder. Okay.
So we got we got two chronal. One on the left looks like a PD fat SAD, and one on the right is just a T1, I'm guessing, T2, of a sclerosing immature patient. And we have, again, abnormality of the some edema at the insertion of the supraspinatus. So actually, it's maybe a little posterior, maybe like inferior spinatus. Supra is actually some traction changes, and then at the axillary pouch again we see a lot of contrast going inferiorly. So it's a little contrast extravasation. So you're worried about inferior glenohumeral ligament avulsion injury and impaction injury. Yeah. So we got an axial. Looks like the anterior labrum. It looks like it also there's a tear. And then on the the sagittal image, again, it just shows the extent of that inferior glenohumeral ligament disruption. It's called also Perthes. Is that what?
Well, forget that. Perthes had a lot of lesions, and it gets confusing. The main thing, like John said, is you just need to describe the anomalies and then say what you think the likely mechanism is in this setting.
Well, HAGL is not a name, so you can use HAGL. I think all orthopods will understand it.
Yeah.
That's just using initials instead of words.
Okay. Jonah, what do you think of this case?
All right, so here's a 19-year-old with a hyperextension injury playing badminton. And yeah, okay, so it looks like we have another HAGL type lesion, inferiorly, perhaps. And okay, so now we've got a couple of axial images, and I guess we're confirming that. But there's a lot of this amorphous, irregular signal intensity, kind of on both sides of the glenoid there.
And also notice that the posterior margin of the glenoid is a little bit flattened.
Okay, so
what's happening here?
Interesting. Well, the way it's sort of layering, I would wonder if there's a hemorrhagic effusion or something like that, and there's blood production. Clot, I guess. Yeah. Okay.
Yeah. Huh. Blood is not supposed to clot in joint spaces because typically the fluid in the joint space will dilute the clotting factors such that you don't get a clot. But this turned out to be a rare clot within the joint space due to an acute hemorrhage.
Well, there's a tear someplace. Blood.
Yeah, there's a HAGL lesion here.
So. That's where the blood is coming in, and then it can clot.
Yeah, well, this was all blood clot, and
so the capsule was disrupted.
Yep, the inferior glenohumeral ligament was torn, with a lot of hemorrhage, and that actually clotted in this case.
I'll ask Max, where does the capsule attach on the humeral head?
Along the posterior inferior aspect of the humeral head? Sorry, the capsule will be more around.
The ligaments and capsule, they're all pretty much the same. It's just the ligaments are thicker. But anyway, where do these structures attach in terms of the neck of the? Well, I almost gave it away.
Like more.
It's the anatomic neck. That's what I was trying to get to.
Yeah.
But the inferior ligament also extends to the surgical neck. So in some cases, anyway. Sorry to interrupt you, John.
That's right. Nothing good. It's right in through here. The part of the attachment of the capsular is right next to the articular cartilage, and then the actual attachment can extend down for a centimeter in this area, kind of between the anatomic and the surgical necks. Right, John? Right in here.
That is correct. That's the only place where you see that. I'm saying that that's the only place. I never say never. So I'm sure there are all kinds of areas that you can have bare spots any place. So, and various attachments.
Yep.
Some haven't been described yet.
Yeah, that's really true. Max, what do you think?
We haven't gone to the pygmies yet, you know.
Okay.
Can I ask Dr. Urgidis?
Yes, ma'am.
When you have clot in the joint, does the blood degradation products do anything to the cartilage? Like, would you have to suck that out or do anything in terms to prevent something chronic from happening in the future?
I really didn't get the question, kiddo. Can maybe John about? I'm having trouble.
Can you hear me now?
Yes.
So when there's significant clot in the joint space and that patient was really young, do you have to go in there and evacuate the blood products and flush out the joint? Or is it okay to let that blood and all of the degradation products absorb over time?
Eventually what will happen, it will just absorb, because you do have an opening there in the capsule. So it's like any place else. Blood will turn to serum and then eventually just disappear. The body resorbs all these things. I have never had an opportunity to suck out any blood from a shoulder that's been dislocated. I never had a reason to, so maybe somebody does these things. I don't know. I've never heard of it.
Okay, thank you.
Clot in a joint is exceedingly
We have
common. Right. Max, what do you think of this case?
we have two coronal. I think this is T2 with a sequence demonstrating a cortical defect in the superior anterior humeral head near the insertion of the supraspinatus tendon. In addition, we have serpiginous dark signal structure along the inferior glenoid, probably a torn inferior glenohumeral ligament from its attachment of the humeral head. So this looks like an inferior dislocation with glenohumeral ligament disruption.
Yeah, and here's another HAGL lesion down here.
Do you have to always be like an inferior dislocation to get this HAGL, or it could be from any direction?
You can have a straight abduction injury. Can also produce it.
I cannot hear you, John.
Yeah, you can have a straight abduction injury and also injure the inferior capsule without necessarily having an inferior dislocation. And then this patient also had a tear of the supraspinatus tendon. And here we can see a lot of the injuries. And okay, let's see.
So we have an axial PD fat set image in a patient who's had an arthrogram, and there's undulation of a low signal intensity structure which attaches to the posterior glenoid, which may be the posterior band of the inferior glenohumeral ligament. And okay.
So this is often called the reverse HAGL. Most HAGL lesions are more anterior than this. So this is a reverse HAGL lesion.
We got a normal side and injured side of two shoulders. It looks like a chronal PD fat set with intraarticular contrast injection. The normal side looks normal, and the injured side looks abnormal. There is a inferior humeral, I'm sorry, labral tear. It looks like with the contrast kind of extending medially, and it looks like the actual inferior humeral ligament from the glenoid attachment is detached. So it's a reverse, or it's GAGL. Okay. Yeah. Glenoid.
So this is a tear from the opposite side, not from the humeral side, but from the glenoid side, right?
Answer a question. If you're looking at an anatomic specimen, or even a shoulder, if you're operating on it before you open it up, can you see the anterior glenohumeral ligaments through the capsule?
Wait, I didn't quite understand. Are you talking about at surgery? Can you see the ligaments through the capsule? Is that what you're asking?
Yes, or anatomic specimen. When you're dissecting, can you see the ligaments when dissecting?
Who do you want to answer the question?
Who was that last? Was that Jonah?
Yeah, that was Dan.
Yeah. Okay.
The question is for me.
Yes.
Can you, I'm sorry, repeat the question one more time?
Can you see the anterior capsular ligaments by looking at the capsule from the outside?
I'm not sure. Like the answer is yes.
No, you cannot.
Okay.
So that should have been a reverse HAGL or a GAGL lesion. So glenoid attachment avulsion on that side. And here's another avulsion from the glenoid side as well here.
And the reason I brought that up is that the surgeon needs to really know some of these things, because he may not be going in the right place because he can't see the pathology. So it's very important for the radiologist to point this out.
Great, thanks, John. And so here's another avulsion from the glenoid side involving the inferior glenohumeral ligament. And here's just a sagittal image where we're seeing a big cyst down through here, which is also an inferior avulsion. And here's just another example where it's a little bit less obvious, but this is the inferior glenohumeral ligament, and it's avulsed off its inferior attachment there as well. Let me just. What? No, I don't think so. But John, the question is, do you leave these to heal on their own?
Not if they're avulsed from the humerus.
Yeah, and even if they're avulsed from the glenoid side, I think you need to fix these, don't you, John?
No, not unless. Well, it's all age dependent. This patient looks like probably elderly, which means it's over 40.
Over 40. Thanks, John. Pretty good muscle development here. This is probably an athlete, I think, John.
Well, I really don't know. Age dependent. Now, here's the story of shoulder dislocations. I'm not talking about epilepsy and that stuff. The acute dislocation of a shoulder, once it's reduced under the age of 20, you have a 50-50 chance of that recurrence down the road, if you operate or not operate.
You're talking about a traditional anterior dislocation, right?
Traditionally, for the most part, it's the anterior, yes.
Right.
But I think you probably apply that to the others. And so it's a difficult decision to make for the surgeon as to who to operate on or not. The answer is probably not quite clear. I think when you have a fracture, I think that's almost a real indication. That's you probably pretty much have to operate on those and fix them because that's an ideal time to do that.
Yeah.
So, but after the age of 40, you only have a 10% chance of recurrence. So, and in between, well, it all varies.
Yeah. My experience is most of these inferior glenohumeral ligament injuries are in younger individuals, and it's typically due to some level of significant trauma. And a lot of them that we see just happen to be sports injuries. And of those, since they're in younger people and sports injuries, the vast majority that I've seen have been fixed surgically.
Yeah, you probably, if you're talking about pitchers, unless you talk about patients with extended arm,
Yeah.
You know, straight up. But what happens is you operate on them and they do the same, and they bring the arm in the same position and the same force is applied, and there goes the repair.
Yeah. Yeah.
Especially if you're using sutures and you're using no bony blocks.
Mm-hmm. Okay, well, why don't we stop here, and we'll pick up and try to finish most of the instability tomorrow. Any other questions?
And
John?
I don't have a question, but I'll give a little pearl here. There are 150 different operations that are done for the shoulder in terms of dislocations.
Yeah. Yeah, which means that no one of them is terrific, right?
That's probably where I'm getting at. But there are very, I think that's the thing about De Palma in '74 when he published his book. That was kind of like a semi-Bible for treating dislocated shoulders. He used the McNuson procedure, which would, all you do is detach the subscapularis muscle and bring it over the bicipital groove and suture it down with the arm internally rotated. So what would happen there, you also would bring it inferiorly to prevent dislocations that are inferior. Most dislocations are anterior inferior, so, and then some are directly inferior, but anyway, that would fix both of these. And that's the only procedure that was actually advised. It was very easy to do. It took half an hour to do it. But then, you know, we realized that the motion was very much restricted. So we started going to other procedures.
Okay, thank you. All right, I'll see everybody tomorrow. Thank you.